Hey guys, so we are in the middle of learning about the malposition. What is malposition? So, if occiput is in the posterior quadrant of the pelvis that I have drawn in the diagram, if it is ROP, OP or LOP, meaning posterior quadrant of the pelvis, then it is called as the malposition. While all the anterior ones are the normal one, and actually LOT is the most common position that we have seen in the inlet part. And during the active labor, while the fetus is rotating, so fetus have to rotate the 90 degree from the LOT to the OA. So during active labor, when fetus is rotating in this direction, LOA is the most common one. While during the delivery, when fetus is totally internally rotated the 90 degree, then it is OA. Now about the malposition, most common malposition is the ROP, and most common cause of the malposition is android pelvis. And what it causes, it will prolong the labor, and in some cases the arrest of labor will happen, and we have to take some action, like as of we have to do the C-section or any instrumental delivery. So let's see ROP in a labor. It is the most common one, so let's learn about that. So ROP in labor, there will be two outcomes. One is favorable and the another one is unfavorable. Now what is favorable? That will happen in the 90% of the cases, and unfavorable will happen in the 10% of the cases. So what is a favorable? That fetal will rotate 135 degree and will come OA position, that is normal during the delivery. So fetus will rotate so much, so long internal rotation will happen. So OA will see in delivery, and most commonly this is possible if the pelvis is gynecoid. While in unfavorable one, what will happen? There will be either short anterior rotation, and fetus will only come at the ROT, that is known as deep transverse arrest, that we will see if the pelvis is android. Now this is the first possible, that fetus can only be rotate 45 degree and come at the ROT, that is known as the deep transverse arrest, and it will happen in the android. Now second thing will happen, that is the short posterior rotation. That was the short anterior rotation, ROT, and this is short posterior rotation, that is 45 degree, and the fetus will come at the OP position. Now then can be two possibilities. Vaginal delivery can happen, and this will be phase 2 pubis delivery, and that is seen in anthropoid position. So if pelvis. So if the anthropoid pelvis will be there, we can very well do the delivery in OP position, that is phase 2 pubis delivery. Now there are chances of arrest here also. Now the third is no rotation, and this is called as oblique posterior arrest. What is the management? So in all malposition, we have to watch for the progression of labor, because we can't directly do the C-section or anything. If the fetus is rotating perfectly, then we have to at least give the chance to to the fetus that it can rotate and might become in the normal position, or if it is not in the normal position, at least still we can do the delivery, that is phase 2 pubis delivery. So there is no need of doing directly C-section or instrumental delivery, anything. First we have to watch what is the fetus is doing, because it is a position. Fetus can very well rotate in the pelvis. That is not an indication to do the C-section or any action. If it is the case of arrest, then and then only we will do the C-section. And if the arrest is happening during the second stage of labor, at the means fetus is in the way of delivery, then we can do the instrumental delivery. But we can only do after ruling out CPD. Now, for the assessment of the passenger, we have Leopold maneuver. So there is Leopold grip, mainly 4 types, and how we have to do. So it is a PA examination. So we have to first take the consent of the patient that I am gonna do the PA examination, and patient should empty the bladder. And what will be the position? So supine position, and legs are flexed at the knee joint, and then we have to expose the abdomen and cover the legs with sheet until the symphysis pubis, and we have to stand on the right side of the patient. First we have to correct the dextro rotation of the uterus, and then take the fundal height and symphysial fundal height. And check for Leopold maneuvers. Now we have to do the Leopold maneuver while facing the face of the patient, except for the last one, when we are facing the feet of the patient. Now Leopold 1 is also known as fundal grip. We have to see what part of fetus is in the fundus. So mostly it is the broad, soft, non-bellotable part, and that is buttocks. Second, Leopold 2, in which we have to see the lateral grip. So what is in the lateral thing? Back and limbs. So how will back feel? That is curved, right, and smooth, and no be irregular will be limbs. Now Leopold 3, that is pelvic grip. So bilateral and fundal, we can now very well know the position of the fetus in the uterus, that is if the transverse lie or longitudinal lie, and in the longitudinal lie also we can see if it is a cephalic presentation or breech presentation. Now by the pelvic grip, what we are doing, we are placing one hand at the pelvic part, and mostly it is gonna be head, so it will be round and hard, and here just one hand is used. This we have to remember. Now fourth is deep pelvic grip. In this we are facing the face of the mother, and we are using the both hands. Now in this we can see we are ulnar border of hand parallel to inguinal ring. If they are converging, then head has not entered the pelvic cavity, and if they are diverging, it means that head has entered the pelvic cavity. So Leopold 4 actually talks about the flexion or extension of the head, means about the attitude of the baby. And Leopold 3 also we can check this. If the head from side to side, means head we can move side to side, it means head has not entered the pelvic cavity and it is not fixed. So we are just confirming this in this one, fourth. Done. Now what is the engagement? So engagement is when the largest diameter of fetal head crosses pelvic brim. So we have to differentiate between engagement and the station. Engagement will count depend on the largest diameter of fetal head, and that is biparietal diameter, that is 9.5 centimeter, and it is fixed that largest biparietal transverse diameter is this, but largest epidiameter change depending upon the flexion or extension, means attitude of the baby. And we have seen different diameters, that if it is well flexed, then it will be suboccipito-bregmatic 9.5 centimeter. If it is a deflex, then sinciput will be palpated, and occipito-frontal will be the diameter, that is 11 centimeter. Now what is a station? Stations are calculated based upon the lowermost part of the fetal head. So how we can check if the head is engaged or not? So we can do PA examination by and PV examination. So by PA, 2/5 of the head will be palpable, and in PV station of the head, so the station of the head will be when the baby is in station 0. So the position of ischial spine. Now how we can actually check? 2/5 means only 2 fingers will be covering the head, and 5/5 means all 5 fingers covering the head. Now in primary, the engagement usually happens at 37 weeks, and in multi, the engagement happens at the onset of labor. So if beyond 37 week in primary, if we see the free floating head, it means it might be wrong dates or placenta previa or polyhydramnios, as we have discussed this 2 causes in unstable lie, or it can be CPD or deflexed head. So when the head is free floating, before you do a PV examination, you have to rule out the placenta previa, because in placenta previa you can't do PV examination, it is contraindicated. Now we are learning about the steps of normal labor. So first is the engagement, then descent, then flexion, then internal rotation, then extension, then external rotation, and then expulsion. Okay, now we have seen this part, how internal rotation happens. External rotation, also known as restitution. And external rotation is in opposite direction to the internal rotation. So head generally moves to 8. So occiput moves in the original position, that is LOT. And in normal labor, delivery of head is by extension. So in first 1/8 of the external rotation, only the head will move. It is known as restitution. It is a part of the external rotation and it is not a cardinal movement. Now we have to learn about the passage part. So in passage there is inlet, cavity and outlet. So first talk about the inlet. Inlet is pelvic brine and it at the station of -5. Now